Out of the 8:30 news on Thursdays, we have a segment we like to call What's Up, Doc, where we spend some time with the experts at Mercy Health. And this morning is absolutely no exception. Our guest this morning is Dr. James Hall. We're going to talk about cardiothoracic surgery. Dr. Hall, good morning to you.
Hey, good morning to you guys.
How's everything going with you?
Just fine, thank you. Just fine.
So you're like the real-life Trapper John then, right?
Yeah, I don't have the Winnebago in the parking lot, but I'm working on it. I like to have a grill there, you know.
That wouldn't be a bad idea at all.
It wouldn't be a bad idea, except for today, obviously. It would blow off.
Yeah, that's not a good grill day. Tell us a little bit about you. Give us some background. Where are you from?
I'm originally from Chicago. I was born and raised there and went to college out on the East Coast. Came back to Illinois, went to the University of Chicago, and then trained in general surgery, which everyone in cardiac surgery has to do first, at least at that time. I did 5 years of general surgery training at the Mayo Clinic and then went to Emory University in Atlanta and trained there for 4 years, including some basic science research, and trained in cardiac and thoracic surgery. Practiced in sunny, beautiful Southern California for about 12 years.
I can see why you'd want to get out of there.
Yeah, terrible. Yeah. Who wants to put up with 75 every other day? Yeah.
No.
And the other days are 80. I mean, right. Who wanted to put up with that?
Not me.
Not me. So anyway, came back to the Midwest. I've been here for a little over 10 years. I was mainly in Wisconsin, and I recently moved here to Illinois, and I don't root for the Packers. Want everybody to know that right off the bat. I'm a Bear fan.
Nice. Good point. Good point right there.
Yeah. So then after that, basically I do cardiac surgery, which is bypass surgery and valve replacement. I also do what's called thoracic surgery, which is lung surgery, thymus surgery. Occasionally, I don't do a lot of primary, what we call esophageal surgery. Occasionally, I help out if someone has a perforation. And I also do sort of a little touch of vascular surgery, which is the carotid artery, which is in your neck, gives blood flow to your brain. And those are the three main areas I work in.
Did you always know that surgery was going to be where you ended up in?
Yeah. I always liked anatomy. I like the mechanistic attitude about surgery. There's a problem, we can sort of fix it. So I've always been focused on cardiac surgery ever since maybe mid portion of college, maybe. Yeah.
So did you always know that medicine was where you were going to go when you're knocking around in high school? Everybody else trying to figure out, if they were going to be an astronaut, a rock and roll star, a movie star, or you were over there with one going, I'm going to have a stethoscope.
I could say rock and roll would be first, and a fighter pilot would be second, and maybe a heart surgeon third. No, just joking. No, I was fortunate. I had parents that really emphasized education. My father was a PhD at the University of Illinois. My mother was a high school teacher and a guidance counselor in Chicago. And they always emphasized to educate and to look at all possibilities. And when I got to college, I was like, okay, this is what I want to do. And I like taking care of people, and I also like science. So that was how I went into it.
And how long have you had the full title that we read this morning?
Ooh, the full title. Well, I graduated from medical school in, it was 86, so okay. 14 years. So, yeah, we're talking about 36 years. I've been MD, yeah.
Outstanding.
That really is outstanding. Now, for people who are, you described it a little bit, but cardiothoracic surgery, first off, I think like many medical disciplines, when you look at what was going on 30 years ago in your field as opposed to how you approach it today, it's got to be mind-blowing.
Yeah, it's definitely a different field. Some of the surgeries we do are similar to what was done, but we do it in a more streamlined fashion. People have been doing it, they've done thousands, if not millions, of bypass surgery. So we're very familiar with what to do and how to do it a little faster, get people out of the hospital, use less blood. We're very, very conscious of complication rate and mortality rate. So we've streamlined that. I think the management when I do lung surgery, is a lot of cancer surgery. And so I think chemotherapy diagnosis has markedly advanced in oncology and in cancer.
You said a couple times you're very interested in science, so I'm sure the next big thing is always interests you. What's next for you guys? You talked about some of the stuff that we've been doing for a while, just maybe in different ways. Is there something on the horizon that's going to change fundamentally the way you do some procedures?
That's a very good question. I think that my cardiology counterpoints or my cardiology colleagues will probably be doing some things through the artery and the vein that won't require major incisions or anesthesia. I think from a surgical standpoint, we are doing some surgeries in we call it minimally invasive. I say less invasive because you still have to be put to sleep and have some surgery, and it has some risks associated with it. So I think there's some changes coming on, yeah.
Are we doing more or less heart surgeries these days?
I would say probably slightly less heart surgeries. I think a lot of heart surgeries, they've been supplanted by some stenting and by some medical therapy, but still we do heart surgeries and we do some difficult ones. Obviously, transplant hasn't changed. That's still need transplantation. I think also with the COVID, we had to put people on an extracorporeal membrane oxygenator, basically something that serves the function of your lungs and, to a certain extent, your heart. And so that was something not relatively new, but really in vogue in the last year or two, and cardiac surgeons have been very involved in that.
Mercy Health's got a little bit of a bio up on the website talking about you. And one of the things that jumped out at me that I really liked seeing is you make these, you discuss medical, surgical, and personal issues that a patient's dealing with at the time of a consultation. When you work with your patients, you discuss the surgery and the post-op care, but you put an emphasis on how this impacts their family. Tell me a little bit more about that approach.
Well, you have someone who's, somebody's, I'm not operating, I may be operating on a patient, but that's someone's father, mother, brother, sister, aunt, uncle, nephew, or niece, and son, daughter, whatever. And so you have to, the family's going to be concerned. They, to me, it might be routine, and I don't think anything's routine unless, you're in the backseat of the car waving goodbye after 4 or 5 days, and thanks a lot, Doc.
Right.
But for me, it's routine. For them, they don't know. They get upset. They cry. They want to know, is he going to be like him or herself after the procedure? Will they be able to go back to work? They're worried about issues of, say, stroke and infection. So they're concerned about all these complications, as are we, obviously. But we sometimes don't verbalize it as much. And, my father, he had been a smoker for a period of time, and he underwent bypass surgery. And I remember crying in the waiting room for him. Mm-hmm. So I know what it feels like to have that discomfort and not knowing what might happen. So
I remember my dad saying to me after bypass surgery that he was relieved because now there's country clubs he can get into that he couldn't get into before.
The Zipper Club.
Yep,
right?
That was it. Yeah, there were clubs. Unless you've had 3 or 4 of them, it's just you're not the kind of person we're looking for.
Oh yeah. But the real thing I can really emphasize to people is how they live their life. They have to get more sleep. They have to stop smoking. They have to exercise. Have to eat better. I mean, all these things that are part of lifestyles have to be changed drastically for people not to have these serious cardiovascular problems. And I'm sure any doctor would agree with me in that regard.
In my very ignorant view of how hospitals work and doctors' lives.
Okay, this should be good. I'm waiting for this.
I've always kind of thought of the heart surgeon, kind of be like the closer in baseball. You just kind of come in and you clean up what's been here before, and I'm here to save things, and I'm done, and I sew you up, and I'm out the door. I grab my golf clubs, and I'm out golfing. I never really. You just talked about your talk with family members. When do you become part of the bedside medical help when you're talking to patients and families?
Right.
When does that process begin with you?
Yeah, that's a good question. First of all, I'm often referred patients, so primary care doctors send patients to cardiologists. Cardiologists do the diagnostic work of angiograms, CT scans, echocardiograms, and then they refer the patient to me. They may call me beforehand and say, oh, this is this woman, she has this, and that. When I see a patient, I go in, I sit down, and I say, I'm going to do your surgery, and this is why we're doing it, and this is what we're going to do, and this is the goal of the surgery. And then I talk about risk and complications. That's when I become part of the team. And I tell them, your questions, whatever they are, you can always ask me, and family members can always ask me. Then just before the surgery, they wheel into the preoperative holding area, and I talk with them again. Last-minute questions. With this COVID thing, it's limited to certain people. They can't be in the hospital room afterwards. So there are impediments to communication because of that. But nevertheless, you have to talk to everyone. I go in the room. I have a great crew that, anesthesia will get the patient to sleep. But I'm usually sitting in the background just in case, because sometimes cardiac disease can become unstable, especially coronary disease during the induction or placing someone to sleep. Then I go in, I make a skin incision, I do all the surgery, I close the bone. I have an excellent assistant who also has some plastic surgery skills. She's a nurse practitioner. She will then sort of close the skin. The patient goes to the ICU, and then I go to the ICU, and I sit outside the room and do paperwork and dictation, but I'm there, and I get every call about that patient, usually, until they go home.
Dr. Hall, you seem like exactly the doctor that many people who are listening right now go, that's the guy I want. That's him. I think I figured out exactly who I want. Now,
well, there are a lot of doctors like me. There are a lot of guys and women in the field now who are very assiduous. They're very, very focused. And it's a contact sport. You're not like the closer. You may close, but if you touch them, you're responsible for them. That's my fault.
Well, we'll have some of the other ones on, and if they can throw out words like assiduous, we might consider them as possible candidates. But
that's an SAT word, right? For all the 17-year-olds.
Right. But unless they use that word, you're still our guy. Okay. For people who are interested in getting themselves a heart checkup, they want to look into this part of their lives. What do you recommend they do from here?
Well, they'll see their primary physician. He'll look at their height and weight and blood pressure. That's the first place to start. Then they'll look at whether they have, what's their blood sugar, what's their cholesterol, what's their lipid levels. That's some basic family practice, general internal medicine. What's your lifestyle? Do you smoke? Do you have lung disease? All these things can be attacked right at the base level of a general practitioner, a general internist, examination and follow-up. When you think there's an issue, when you think there may be coronary disease or an irregular heartbeat or heart failure or a valve problem or maybe a lung cancer, then you transition to a specialist. Cardiology for the heart, a pulmonologist for the lung. Sometimes, we can get CT scans without conferring with the pulmonologist, but they're the experts on the function of lungs and whether people then can tolerate it. And they also have a medical oncologist who then gets involved if they're so there's before you get to the specialist, you can look at some of your own issues and concerns. And I'll be frank, the general internists work hard, and they don't sometimes have time to spend 30 minutes with everybody counseling them. They do, but then people walk out the office and go eat a hamburger and fries.
Right.
Sounds good right now, doesn't it?
You know that chat's over. A bacon cheeseburger go down real well here. Yeah, that's probably.
Yeah. Well, yeah. I'll see you later, guys.
Yeah. No, you don't want to hear that from a guy like you unless it's a complete social
You
setting.
want to get to know me, but not too well. That's
Right.
Well, we've enjoyed what we've gotten to know this morning, Dr. All. We appreciate you taking time out of what we know is a very, very busy schedule and taking some time to enlighten us this morning.
All right. Hey, it's been my pleasure. Call me back anytime, guys.
We would love to. Thank you very much. That's
All
Dr.
right,
James
good
Hall
morning.
with Mercy Health.